So how do you go about doing this within your own organizations? Well, the number one thing that you need, as we mentioned before, is you need some type of a comprehensive data source, right? You need to know the most up-to-date HCPC pricing. You need to know what NDCs are within specific HCPCs, and this changes readily, especially with products that have generics. You have products being terminated. You got products being approved by the FDA coming to market. You got an NDC shift going on. So you need to keep up with that. It's not one of those one and done things. Also, you need to know, all right, well, yeah, great. I know that the HCPC maps to NDC, but what does that mean? What should the HCPC price be for specific NDCs? And that's where that unit conversion piece comes into play. And finally, the maximum unit piece is just a good indicator of what is the max threshold that I should be looking for. What is a trigger to do something. Using those different types of data to build your own modeling or working with somebody else to do the modeling for you, then supports your overall drug management process, right? You can use it to improve your contracting. So if you notice that a drug is significantly increasing in price, and let's say you don't, and I use a dirty word here, you don't have a rebate in place, then maybe that should trigger that discussion to go to the manufacturer and say, well, maybe we need to contract a rebate, or maybe our rebate needs to be optimized. Also, as you're managing your fee schedules for your providers, if you do have any contracts that have specific pricing in there and not just discount rates, then you probably want to go dig those up and modify them for these drugs that are having either significant increases or decreases in pricing. Or if there's a significant decrease in pricing, you may want to reevaluate the discount rate within the contract as well. Finally, as I showed you before with the improved utilization management, if it's exceeding a certain price, that should there should be a trigger to take a deeper look to make sure that either utilization management is working correctly, or if you don't have utilization management in place, that maybe now is the time to seriously consider putting some type of a control in place. And then, of course, many organizations do their own modeling, so this type of data helps to support modeling, similar to what we've done here. It also could trigger either formulary reviews or maybe a need to update in a historic formulary review. And then finally, from an out-of-network claim pricing perspective, if you're getting a claim from a provider who's not in your network and the price is astronomical, this gives you kind of guidelines in regards to what should be the fair market value for that drug based off of the data service, right? So if the doctor's pricing, as we saw those drugs with huge price increases, if they're pricing the drug based off of today's price, but the data service, let's say, is 2 years ago, just as an extreme example, then you shouldn't be reimbursing at today's price. You should look back, and that could be 100%, as we saw, or whatever it might be, percent lower price. And if you use that price, then that was going to result in a significant price savings for a payment.